was actually emitted on the day 1 itself for sugar monitoring. But however, it was quite uneventful. After 24 hours of admission, the child was being discharged well. Thriving along the way, at 6 months of age, he was then admitted to SGH for some viral URTI. However, incidentally, found out by our pediatric colleagues that this child have a macrocephaly with head lag at 6 months. Otherwise, the child was well. There is no sign of increased intracranial pressure, and he doesn't require any oxygen support, and there is no documentations to pinpoint any problem with saturations and hypoxia. In view of the primary problem itself, he was admitted again electively for MRI brain. He had some brief desaturations after sedation, require oxygen 1 day, and managed to off it with a good saturation before we discharged him home. And in the early of December 2021, the mother actually has noticed the child had some fingertips bluish discoloration for about 3 weeks before he was reviewed in local clinic establishment. The mother didn't seek for medical attention as the child was well and is not in distress. On the 24th of December, this is 3 weeks after the mom noticed the child have bluish discolorations of fingertips. He brought the child to have doctor examinations because the child have URI symptoms. He was then referred to SGH in view of persistent peripheral cyanosis and unable to maintain saturations. Documentations was written as 82% SpO2 under room air. However, the child was rather comfortable despite of having mild URI symptoms. The features with this child, he has clinically it should be a macrocephaly with mild head lag, fingertip cyanosis with otherwise comfortable, not tachypneic, not in distress. SpO2 was 87% in our ETD and able to achieve SpO2 of 96% on high flow nasal prong oxygen of 2 liters per kilo. All right, the initial investigation, it wasn't too striking, except for transaminitis and borderline high ammonia, serum ammonia. And if you look at the FBC, there's not much of information that we can get. Bills are okay. AST and ALT, there's a transaminitis increase about 2 to 3-fold. Ammonia normal value is 40 and below, and this child is ranging from 195 to 212. And the arterial blood gas is quite interesting to see that he has a persistent type 1 respiratory failure where the PaO2, the partial pressures of oxygen, is only 47.1 on room air, and on the oxygen 3 liters is 56, and only managed to achieve more than 70 on the 16 liters of oxygen. That is all taken from the arterial sample. However, the lactate is less than 2. There's no hyperlactatemia. We was trying to figure what is the problem and what is the diagnosis that we are looking at. Differential would be the most common one. Is that from the heart, congenital heart with right to left shunt? Is that from the brain, whether the child have any intracranial pathology that leading to a central origin of cyanosis, or whether is it problem with the lungs, whether he has undetected pulmonary hypertension or any kind of shunt that leading to this persistent cyanosis. So subsequently, we have proceeded to a series of investigation. This is the chest X-ray of the baby, which shows increased perihilar markings. The lungs looks wet, and as well as the heart borders, there's a borderline cardiomegaly. All right, this patient that time was on high flow nasal prong AVO 2 liters per minute. Interesting to show you the subsequent bedside echo with agitated saline bubble test. All right. Oh, please play, please play. This is the most important slide I want to show you all. My God. Can I show it here? Separate file.
Yeah, you can show it outside PowerPoint.
Yeah. This is the most important slide I have to show you all.
Khiu, you don't mind I share? I share the slide. Khiu, are you there, Khiu?
I think they log off got the jaw.
They're gonna log off, huh?
Yeah.
Okay, okay. Yeah, I'll just show you the slide. See whether I can. Can you see the slide?
Yes, can see. Yep.
Okay, right. So this is the slide that Khiu will want to show. Yeah. Asliani, what do you think that what's the echo trying to show? Or anyone can would like to try and see what's the echo trying to show.
Hi, Dr. Chow, Chingy here.
Jenny, yes.
No, this one is a bubble test. There's a right to left side, means the bubble like go from the right heart to the left side to the AST, the PFO or AST. So it means that, and also I can see that the IS, the intratranseptal is a bit bulging to the left side. This means that most likely the child might have some degree of pulmonary hypertension that might cause the what the cyanosis, the oxygenation is not good. I don't think the child has some pulmonary hypertension.
Pulmonary hypertension. Okay. So what is against of pulmonary hypertension here?
What is against the pulmonary hypertension? Because let me think.
Yeah.
Because I can anyone can help.
Anyone else want to try? Yeah, don't worry.
No,
Yeah,
no right heart hypertrophy.
Yeah, yeah. There's no sign suggestive of right heart strain. There's no right ventricular hypertrophy. And yes, and then the right heart is not enlarged and dilated. Yeah. Anything else? Yeah. So pulmonary hypertension. Yeah. Yeah, it is probably not shown here. Yeah. no doubt if we have a significant pulmonary hypertension like MAS, we used to have a ASD, yeah. So then we do a bubble test, then it will be a significant right to left shunt through the ASD, yeah. And then that create this kind of turbulence. Yeah. Anything else? Anyone else? Q had not come back, is it? Q, are you back? Because Q in OT, so sometimes the line not good.
I think it's line, Dr. John.
It's line, huh? Yeah, I'll give you the call. Yeah. Anyone else wants to try again? This is I think this is the most important slide that you want to show. Yeah. Yeah. Anyone want to try?
Shows that. Okay, I will try.
Yeah. Okay.
Okay, so the bubble is seen on the left side, nearly quite fast, immediately less than a few cardiac cycles. So that by right, if there is no right and left heart connection, meaning if there is no septal defect, we should not be seeing all these bubbles, as these bubbles will be filtered by the lung. So the fact that it is present, it just
Yeah, we lost Olive also. Q, are you there? Hello. Q, are you still there?
Lost,
Don't worry,
lost.
we're waiting. Don't worry. Yeah, we continue. Who else wants to try? Or Olive pun tekan gas. Came out already. Yeah. Anyone want to try? I think that is the most important slide we are showing today. Yeah. Or anyone want to continue the comment?
Dr. Chua, can it be possible if let's say just some like something?
Can you hear me?
Yeah, we can hear you back. Yeah, can Q can hear you back. Yeah, carry on, Chong. Chong, carry on.
So means because like this one is a 4-chamber.
Yeah.
I'm not sure whether there's something like some shunting, some extra like what you call collaterals or some shuntings that cause the bubble test to be shunt from the right to the left.
Yeah, good.
I'm thinking because I'm not sure like some collaterals or some like some abnormal of the vessels that cause the bubble test to be shunt from the right to left. If just not by thinking that the pulmonary hypertension is unlikely the cause because of the like right ventricle is not hypertrophy or that's like against the pulmonary hypertension. So another thought I can think of is some collaterals or some malformations that there's a shunting in between. This is what I my thoughts, another thoughts.
Yeah, good. Yeah, okay, good. Yeah, there's some shunting. So where is the shunting? Q, you want to continue?
Yeah, actually where I stopped, Dr. Chong.
We just show just now I managed to pull out the image. Yeah, the echo image. So we finished the echo image, but conclusion belum the conclusion yet. You want to try and show? Yeah, you want to show your slide now? Yeah.
So the final diagnosis we put it as Abernathy malformations with polysplenia syndrome. All right, I will explain to you shortly what is Abernathy malform. Okay,
no,
so
Q, we have not see your slide. Yeah, and then can you explain the echo finding? Yeah, we have not explained echo finding yet. Yeah.
Yeah, can you see the echo video playing?
Not yet. You have not shared your slide.
I have not shared my slide. Okay.
Yeah.
All right. Sorry, a lot of technical problem. Start broadcast. Yeah. Can see?
Yep.
Not your slide yet. Yeah.
Not my slide.
You can see your screen.
How about now? Can see? Can see?
Only your screen. Yeah.
Only my screen. Because
Mm.
now
Change display.
I'm actually watching the
Oh,
echo.
okay. Okay, that didn't come up.
Yeah, the
Oh,
display in your iPad too.
It's still on my screen, eh? I think the line is slow.
No worry.
Somehow.
Yeah.
Okay. Very sorry. Already on the sharing mode.
Yeah. We only see your main screen. Or maybe I share for you. Yeah. Okay, you unshare, then I share for you. Yeah.
Okay.
Okay. Yeah, you unshare now, I share. Yeah. Can you see the screen?
Yeah, Dr. Chow.
Okay, all right, yeah. So now this is yours. The slide we stop here. We had not explained yet. Olive will explain halfway. Olive, you want to explain it on top of what Cheong had said? Yeah.
Oh, okay. So by right, when we are doing a bubble test, the bubbles cannot be seen on the left side of the heart as it is filtered by the lungs. Provided that the echo shows normal intracardiac features, meaning there is no septal defects or any communication between the right and the left heart, we should not see the bubbles if everything is intact. So the fact that we can see the bubbles in the left side of the heart in less than 5 cardiac cycles, it just means that there is a communication. So in this case, I assume there is no septal defect because we are only seeing the 4-chamber. We cannot say that there is an ASD from this view. We will think of some form of AV malformation. As Cheong rightly say, she's thinking of some communication or some malformation. And Q has already told us that this is an Abernathy syndrome. So there is an AV malformation, and I will let Q explain what's Abernathy syndrome.
Yeah, and then before that, you have to be very careful when you look at this echo. So we are doing a bubble test, right? So a bubble test that we are actually preparing some saline, or I like to use gelafantine and then agitated with it with some gas, right? And then inject into the patient intravenous line, and then we do the echo and then see the pictures. And then you see carefully. So the cardiac cycle, the moment when you see the contrast over the right side, you did not see immediate on the left, right? So that tell you that it is unlikely, less likely to be a ASD, because if the ASD, a lot of time you can see quite immediate effect, especially when you look at the in the case of pulmonary hypertension. So there is a significant right to left shunt. So the bubble you will see quite immediate after when contrast went into the right atrium. Yeah, but this is not. So there was a delay. There's a significant delay after 2 or 3 cycles. Then only you see the bubble. It tell you that the bubble does not come from the atrial septal defect. Yeah, or any ventricular, even the ventricular septal defect, but it is somewhere happen in the lung. Yeah? So that means the communication occur in the lung that create what they call that. That create a shunting that you can see. Okay, yeah, he will carry on. Yeah, you just tell me with the slide to go on. Yeah.
Yeah, thank you, Dr. Chow. So actually, in fact, after this test, we have done a CTPA for this patient to rule out AVM of the pulmonary system. However, it was a negative finding, which make the diagnosis even more challenging. So subsequently, we proceed with a CT abdomen because the bedside echo has also shown us abnormal portal veins appearance. So on the right hand side, this is a normal reference of the CT of the liver. As you can clearly see, the left, middle, and right hepatic veins are patent and is normal looking. IVC is actually situated below the right hepatic veins, which is appear to be normal as well. The next subsequent slide, I'm going to show you the sagittal view, also axial view of the venous systems. And you can see here the splenic veins, left and right renal veins appear to be engorged. And the hemiazygous veins actually next to the left kidneys is also appear to be dilated. And from this study, we can't locate the portal veins. It's either we don't see it or there is a congenital absence of this portal system. The slides below my right hand side, I want you to pay attention on the spleen. Okay, the spleen appear to be bilobulated, which in keeping to polysplenic appearance, right? Okay, the following slide. Okay, so looking at the appearance of the splenic and superior mesenteric vein, I don't have a normal picture to compare to, but from the gross examination, you can see both splenic and superior mesenteric veins are much dilated. So in case we have seen this appearance in the CT finding, a few differential diagnoses we have to think of. I've discussed this case with our radio colleagues. They give me a very good input in terms of dealing with all these dilated venous system in the portal venous study. So in a chronic pathology, especially when they are dealing with portal hypertension, liver cirrhosis and all that, the splenic veins and superior mesenteric vein, they will appear to be engorged. But again, looking at this system, usually they will also find the enlarged venous system in the esophageal-gastro junction, as well as in the periumbilical vessel system, which does not appear in our study. And at the same time, when we scroll off the CT images, we can't find the portal vein in this study. That is the acute pathology. So that is a chronic pathology. But whereas on the acute setting, if you have patients who come in with an acute problem with all these splenic or splenic mesenteric veins dilatations, then we have to suspect about portal veins thrombosis. But however, as what I said, we can't find any portal vein in this study. Or if there is a portal vein thrombosis, then it should be associated with some filling defect in the portal veins. All right. On the right-hand side, the CT scan, whereas I show you, interestingly, the small intestine is situated on the right side below the liver. On the left-hand side, you can't see any small intestine, right? So this patient also have a small intestine midgut valve malrotations as well, okay, which consistent with the features of polysplenia syndrome. The next slide. Just to show you the appearance of the arterial system, celiac trunk, superior mesenteric artery, and inferior mesenteric artery. In a normal condition, the celiac trunk should be bigger in size as compared to SMA and IMA. However, you can see the celiac trunk here appear to be small. Next slide. So our final diagnosis, we have called it as Abernathy malformations and as well as polysplenia syndrome. Okay, next slide. So on the discussion, I will highlight to you three parts to discuss. The next slide, part one, I will tell you what is cyanosis, types of cyanosis, and what will be the potential differential diagnosis in dealing with a child with cyanosis. Number two is about the echo bubble test. Number three is Abernathy malform with its association features. Next slide.
Khiu, nak tanya,
Yeah.
do you have blood gas?
Sorry, blood gas. Oh, I actually
So it's
put
just
it in the
PO2 je?
yeah. The previous yes. So the initial diagnosis yeah. This slide didn't appear during the presentation just now, huh?
Ada. Yeah.
Oh, okay. So this patient have a persistent type 1 respiratory failure actually. The PaO2 was only 40 something in under room air, and it's only managed to achieve more than 70 when come with a AVO of 16 liter. Right. Okay. Okay. So the next slide. So cyanosis is actually a changes of body tissues colors to a bluish purplish hue as a result of having decreased amount of oxygen bound to hemoglobin. Of course, the body tissues that reflecting cyanosis are usually located on the skin, which is appear thinner, including the lips, nails bed, and earlobes. So from the wording cyanosis, Greece language, the cyano means bluish discoloration from the wording of cyan. Okay, so this is a clinical description which has no concern with any biochemical or any laboratory interpretations. So the type of cyanosis can be, the next slide, can be divided into central or peripheral. Just to keep the slide a bit more interesting, actually quite a numbers of animals, they have central cyanosis. So one of the famous pet chow chow have a blue tongue. All right. Okay. Out of topic. The next slide, Dr. Cho. Central cyanosis is an evidence of when the systemic arterial concentrations of deoxygenated Hb are exceeding 5 gram per deciliter. And of course, when the patient have severe anemia with a Hb of less than 5, the cyanosis might not be apparent. Whereas for peripheral cyanosis, it can be either a normal condition or as combined pathological condition as part of central cyanosis appearance. This has a normal peripheral cyanosis. Usually the patients have a normal systemic arterial oxygen saturation. However, with the increased oxygen extraction results with a wide systemic arteriovenous oxygen differences and increased deoxygenated blood on the venous side, it can also appear to be peripheral cyanosis as well. Just to recap on our neonate who just delivered with polycythemia and all that, usually the patient will appear to be venous congested and they will have appearance of peripheral cyanosis. And these conditions also will be elevated, especially when the patient is exposed to cold, when there is a peripheral venous obstruction, when there is problem with low cardiac output secondary to sepsis and all that. That is also can be pathological. The next slide. So the differential diagnosis on the cyanosis, it can be further divided into either is a ventilation perfusion mismatch, airway disease in neonate, it can be due to TTN, RDS, the congenital pneumonia, aspiration, or pulmonary hypoplasia, pulmonary hemorrhage, and congenital CCAM. And extrinsic compressions of a lung, example of a pneumothorax, pleural effusion, or hemothorax can cause cyanosis as well. Coming to more challenging differential, like any problem concerned with right to left shunt, like cyanotic heart disease, obviously they will give you a cyanotic appearance. Okay, that is quite obvious. And especially the rarest cause will be intrapulmonary or extrapulmonary shunt. Example like pulmonary or extrapulmonary arteriovenous malformations will give you bluish discoloration as well. In our patients, we have in our patients that I mentioned just now, Abernathy malform. This patient is an example of extrapulmonary arteriovenous malformations. Next slide. Other causes like from the CNS, patient have intraventricular hemorrhages, prolonged seizures, meningitis, encephalitis. Also can have alveoli hypoventilation leading to cyanosis, airway problem, neuromuscular disease that leading to hypoventilation. All these will cause ineffective breathing leading to cyanosis, diffusion impairment like pulmonary edema, pulmonary fibrosis, methemoglobin with decreased peripheral circulations, example like sepsis, shock, polycythemia, hypothermia, low cardiac output. All these are contributing to peripheral circulation reduction leading to cyanosis. Okay, the next slide. Okay. Okay, what is agitated saline bubble test? I don't find any, I can't find a proper pediatric recommendations, but from the American Heart Association recommended for adult, they recommend 10 ml syringe where they use 9 ml of either agitated normal saline or gelafandine, like what Dr. Cho have preferred to use, with 1 ml of air. Then they will inject the 10 ml of this contained into the patients. But for pediatrics, what we have done in SGH with Dr. Cho, usually we will use either gelafandine, 1 ml, then we will agitate using two 10 cc syringe, and we'll inject in less than 1 ml of volume. Okay, so the next slide, I'm going to show you how this process is being done. You need a three-way, two 10 cc syringes, and which connect to the patient's granula. Okay, preferably if you have a lock-in 10 cc syringe will be a better idea. Otherwise, it will be split out when you apply the pressure. Other than that, if you don't have it, then you can hold the two 10 cc in your palm to avoid it from separated from the three-way. Okay, this is how we do the agitations of the saline. So can Dr. Cho play with the video? So the constant pressure is being applied so that we can imblend the air into the solutions that we wanted. Then this bubble will be injected. This bubble containing solution will be injected into the patient in a small amount to create the contrast kind of appearance on the bedside echo study. Okay, next slide. Oh, Dr. Cho, just to give extra information about these selections of saline or the gelafandine. Apparently, from the recommendations, the gelafandine can give higher echo sound when they inject with gelafandine. That's why they usually use agitated saline. But the pro and cons about the gelafandine as a colloid is easier to generate the air bubble compared to normal saline. Okay, so indications for the echo bubble test study. What can we gain from doing this echo bubble study? Number one is, of course, detection of shunt. So it's either intracardiac shunt or extracardiac shunt. So extracardiac shunt can be any form of pulmonary or extrapulmonary shunt. Number two is to intensify the tricuspid regurg signal, especially when you have difficulty estimating the RV systolic pressure. Number three is delineating the right heart border and masses, including the RV wall thickness, especially when the window is very tight. And number four is improving the images of the pulmonary trunk and its arteries, especially when looking for the thrombi to serve as a contrast to see the filling defect. And number five is during the echo-guided pericardiocentesis, where by doing the bubble test, you can see there's any injury to the insertion point that leading to the leakage of the bubble into the pericardium. And last one that we are frequently doing in our PICO is for central venous line control after insertion. So what we did after the central line, we want to see the positions of the tips of the PICC. Number one, of course, we will review as a direct visualizations after echo, under echo. If we can't see it under the echo, then we will do the saline bubble, the echo bubble test. If the bubble test is clearly seen, then we are quite convinced the PICC tip is in the favorable place without needing to do a chest X-ray. The next slide. So what is Abernathy malformations? Abernathy malform is actually discovered by this English surgeon, Sir John Abernathy in UK, where he found it in a 6-year-old child who died with an unexplained cause during the autopsy. So this Abernathy malform is an example of extrapulmonary AVM, where the portal vein is either hypoplastic or congenitally absent, and these splenic veins and superior messenger veins are directly drain into the inferior vena cava. So the next slide will show you the easy diagram to describe the types of Abernathy malform. As you can see, the normal anatomy is very easy. The superior splenic vein and superior messenger vein will form the portal confluence. They are drained to portal vein, and this portal vein will bring all the toxic, like toxic and absorbents from the intestine and filter in the liver before they drain into the inferior vena cava. So without this pathway, these splenic veins and superior vena cava, the superior mesenic veins will directly drain into IVC. So there's a type A, type 1, and type 2. Type 1 is the complicated one, where the portal veins is absent, and these two veins will drain directly into the IVC, whether they are combined together before they enter to IVC, or they are separated separately go into IVC. Type 2 is more straightforward. Portal vein is present, but there is presence of a fistula or shunt between the portal vein and IVC. Okay, so the next slide. Clinical features are consistent with portal vein absence of portal vein, where there will be a dilated intrapulmonary vessels and hepatopulmonary syndrome. These diversions of gut-derived toxin to the systemic circulation will lead to early hepatic encephalopathy or diversions of vasoactive mediator into the systemic circulation. So this diversion of vasoactive mediators, they will lead to the so-called hepatopulmonary syndrome, where the pulmonary vasculature, the veins will be dilated, all right, and leading to this malfunctions of oxygen delivering capacity of the lung. All right, when the conditions prolong, leading to ventilation perfusion mismatch, the patient will start show sign of chronic hypoxia, where it's a digital clubbing, varying of a degree of dyspnea and exertions as a result of portal pulmonary hypertension or portal hepatopulmonary syndrome will occurs along with time. And when this toxic substance accumulate in the body and subsequently achieving the toxic level, then it will subsequently cause hepatic encephalopathy. All right, hypoglycemia as the results of ineffective degradations of insulin from the liver will cause subsequent hyperinsulinemia in the blood, leading to hypoglycemia. And last, the patient will appear to be cyanosed and persistent hypoxemia. The next slide. Diagnostic criteria, of course, we need very detailed medical history and examinations. Early blood parameter disorder in Abernathy malformations, you can see transaminitis with high serum lactate, as well as blood gas will show persistent type 1 hypoxemia. We need a bedside ultrasound and echo to carefully inspect the vasculature of the pulmonary, the portal vein system, as well as we can do a bubble test to rule out any intra or extra pulmonary shunt. And last one, then only we proceed to CT angio with a portal venous system imaging, right? This entity is not standing alone. It will associate with a lot of congenital abnormalities such as congenital heart disease. Our patients have an intra-atrial septal defect. Then polysplenia, which present in our patients, biliary atresia, malrotations, duodenal atresia, annular pancreas. Our patients as well she has mild degenerations of pancreatic tails, which we don't see any pancreatic tails in the CT study. Situs inversus as part of the polysplenic syndrome, anomalies of renal tract, and also skeletal anomalies. All these can happen as a blend of all these entities. Okay, the next slide. So the management of this Abernathy malform is very straightforward, but yet quite difficult and challenging. For type 1 malform, the what you call the management ultimately will be liver transplantations with portal veins reconstruction. But for our patients, I have discussed with our pediatric surgeon. They discussed the case with Dato' Zakaria in HKL. It seems they haven't come to a conclusion. Most probably, they can't offer much for this patient. But whereas for type 2 malformation, these patients can have interventional radio to block the fistula and the shunt, which can be easily surgically or percutaneous transcatheterly corrected. Okay, so coming to the subsequent slide. So with that, I have end our presentation and ready to take any question from you all. Any questions from the floor?
Thanks a lot, Khiu. Yeah. And Prof. Anis got a question.
Yeah.
Yes. In the end, what's the plan of management for this child?
Sorry, Prof. Anis, your
What's
voice.
the management for this child in the end?
At this point, we have sent a child home with low flow nasal home oxygen, 1 liters. We are still waiting for the final decisions from Dato' Zakaria, what will be the further plan. But as we know, the liver transplant will be the ultimate management for this child. I'm not sure whether they'll be able to do for this patient or not. But he will require the higher support, whether in HTA, definitely not in NGH, if the decisions of liver transplant is being made.
The prognosis for this child in terms of the overall condition?
Overall conditions, the patient is still appear well. I think if the liver transplant can be made for this patient, then of course the lifespan can be prolonged. But there are also a few limitations for this patient. I didn't mention about the overall features. Actually, the patients have also some intracranial pathology, subarachnoid cyst, and global developmental delay. How far the child can go, couldn't be sure at this point, but it's going to be a complicated case.
Thank you, Khiu. I missed your
Prof. Tan?
initial presentation.
Yeah.
What is the underlying medical condition of the child?
He has a few problems. The first identified issue was the macrocephaly. He has this congenital aqueduct stenosis leading to some sort of like obstructive hydrocephalus. He has also subarachnoid cyst as well. Then along the way, when we investigate him with the brain imaging, then we notice he has desaturations. Then we further work out for the unexplained hypoxemia. Then only subsequently we find out he has more problem than what we have expected. So also of this Abernathy malform to the end.
Okay. And the liver function, is there any derangement in enzyme and?
Yes, he has a transaminitis. All the AST and ALT was taken on 6 months of age. No hepatitis picture, but transaminitis. Bilirubin and albumin is normal. The AST ALT increased less than 5-fold compared to normal. Ammonia is also slightly high, which consistent with the features of Abernathy, where it's evidence or reflection of the unfiltered blood from the gut into the systemic circulation.
What's the INR?
INR was normal for this patient.
Oh, okay.
No bleeding tendency. Maybe the manifestation is still early. The child haven't go into the irreversible liver failure yet.
Yeah. Okay, thank you.
Yeah, but of course, if the decision of not doing anything, I think the full-blown clinical manifestation might be appearance before the age of 1, because yeah.
But do you have a sign like a patient who has liver failure with white pulse pressure and then albumin is how much? Thanks,
Albumin, this patient is 38 to 42. I didn't put here. Yeah, it's normal. It's normal.
So look like liver not too bad. So the
Yeah.
liver transplant probably still has quite sometimes, because sometime for you to what do you call to work up and then see what else that you can do before I talk about transplant.
Is it okay if I share an Abernathy syndrome that I saw many years ago in Miri?
Yeah, Olive.
Yeah, so I saw I think she's around 10 to 12 years old. She also presented with cyanosis, but of course her echo was normal, only the bubble test was positive. But on top of the cyanosis, she actually, the main concern was meningitic syndrome. She had multiple brain abscesses. Following that, I did have a read up on Abernathy syndrome. They actually do very poorly despite liver transplantation. Like Prof. Gan pointed out that they may have a few years more before the liver transplantation. That's right, but irregardless whether they are transplanted or not, the overall prognosis is poor. What I wanted to say, that girl, even though she was already 10 years old, her liver function, only the liver enzymes were mildly elevated. So what exactly happened is because all these humors and toxins are bypassed from the liver, and hence the ammonia is high because it is not cleared, but it just recirculated again. And all the humors will then cause the AV malformation, not just in the lungs, but in other areas as well. So I'm not sure whether the arachnoid cyst is due to the liver pathology or not. The girl had clubbing, like all the manifestation of severe prolonged hypoxia, clubbing, cyanosis, but she has relatively normal liver function except for deranged AST, ALT, no coagulopathy. But of course, in the end, she passed away due to multiple neurosurgical intervention. She could not even go on to further investigations for the Abernathy syndrome. The Abernathy syndrome was picked up incidentally as she presented with brain abscess.
Olive, just an interest, personal interest to know, what makes you decide to do a bubble test in this patient when you do the echo?
Because the echo did not show any intracardiac abnormalities, but she was clearly cyanosed. Her saturation was only 76 and I think about 70s, and she required oxygen therapy. This child was from a very rural area and was referred to me from Limbang. So Limbang thought that she was a cardiac problem and then referred to me. Because of the absence of any intracardiac abnormalities to explain the cyanosis, hence the bubble test was done and it's positive. So the only thing that could be was AV malformation. And this patient was then referred to Dr. Martin to confirm my echo findings, and he noticed that the portal vein was abnormal during echo, and that's why we had a CTPA along with a abdominal scan. Otherwise, we do not have any other positive findings except besides the the neurological signs. So that from the CT scan, we confirm the diagnosis of Abernathy.
Thank you. Interesting. I just want to share some of my literature review on this Abernathy malform. I guess many of the cases might be just, underreported because of lack of exposure to this entity. In fact, some of the cases were shared by the pediatric cardiology forum, where when the patients were having a congenital heart defect after operation and during follow-up, they noticed that the patients have unexplained, what you call the unexplained abnormal liver functional test. So when they look back, then only they notice from the echo the patients have abnormal portal vein, and they further work out, then only they found out the patients have Abernathy malform. So just I'm also reflecting myself on how many congenital heart that I've seen with a liver functional impairment. So it's a diagnosis by a very careful suspicion. So again, I said if our mind don't think, then our eyes definitely won't see it. So any abnormal result might have give us an early signal of certain diagnosis. Yeah.
But we have to remember that hypoxia can also cause abnormal liver function. So it may not be Abernathy as well. It is a very rare condition.
Yeah, of course, of course. Okay.
Any other question? Olive, you want to pull out your paper and then your paper on the Abernathy, the one that you wrote, and then you share in the groups. Yeah.
Okay, I will find. I'll share in the group later.
Yeah. Olive did write out the cases the case that she mentioned earlier. So it was published in the paper, and yeah, so it'll be good to share. Yeah. And before we proceed further, I think the other important thing that it's worth mention is that the X-ray. Yeah. So anyone want to comment on the X-ray? Any taker? Just try. I mean, you go through the CT scan already, so now retrospectively, yeah, do you want to say something about the X-ray? Who's there? It's a fellow. Wei, you want to try? Wei, Li-Ling, you want to try? Oh, Myra, so we run away. Okay. Wei, you want to try?
That the lung look congested.
Yeah, good. Yeah, so the lung look congested. Anything else? Yeah. Try to look at the abdomen. Yeah. What do you notice about the abdomen? Good, because
Liver small.
yeah, liver small. Okay, yeah, the liver is literally small. Okay, what else?
The bowel gas can see obviously overlapping with the liver very high up. The
Yeah.
small bowel.
Yeah. Huh? So this thing, the bowel, the bowel, gastric bowel was on the right side, huh? Very prominent. Liver look a bit smaller, huh? And then the left hypochondrial area look very full, huh? So when you have this kind of appearance, huh? Sometimes you need to click yourself whether it's some form of situs or not, or the liver is in the midline, huh? So yeah, so we look at the X-ray. Huh? So not only look at the lung and as well as the this thing, as well as the heart. Yeah, also look at the abdomen side. Huh? So any more questions regarding this one, the echo finding? I think this is the most important things that can diagnose quite a few abnormality. Any question for this bubble test? Are you confident to do the bubble test?
Yes.
Right. Okay. Yeah. Any question? Any more question before we end the session? Okay. All right.
So,
Yeah.
sorry, I got
Sorry.
a question.
Yes, yeah, Chi. Yes.
The Michelle here, I'm using Chi's
Michelle.
laptop.
Michelle?
So this patient actually has a hepatopulmonary shunt, right?
Hepatopulmonary syndrome.
Yes, correct. So it's a hepatopulmonary syndrome. Yeah.
So it's actually a shunt from liver straight to the pulmonary vein that leads to this positive bubble test.
Can. Yes, that's right. So
in this case, will retrospectively looking back at the X-ray, does it consider it causes like those kind of wet lung kind of appearance? Is that so?
Not really. Yeah. So yeah, it can be a bit more wet, congested. Yeah, a bit more because of the pulmonary venous congestion. Yeah. So it might appear a bit of congested origin. Yeah. Yeah.
Okay.
Yeah.
And then we couldn't differentiate based on this bubble test. We cannot differentiate.
Meeting.
Pulmonary shunt.
Saya tinggal dekat sana, sini tak ada line. Sana tak ada line.
Pasal
dia mau keluar ha.
Dia komplain lah sudah lama dia cakap
sure. Boleh saya keluar sudah. Ha? Okay. Sorry. Carry on. Yeah.
So this bubble test is just to be sure that it's not intracardiac shunt, and then we wouldn't know whether shunt is in the intrapulmonary shunt or is a hepatopulmonary shunt. That's why need a CT scan to rule out the intrapulmonary shunt. Then only we can deduce this is due to liver. Is it?
Again, can you rephrase your question again?
I think I can get what Michelle is trying to ask.
Okay. Yeah.
Yes, what Michelle said is quite true. Is finding the last piece of the puzzles is a process of what is more common come first. It's just like how we deal with this patient when we see positive bubble test. The first thing we have exclude the intracardiac causes. Then the next thing actually we are looking for intrapulmonary. I didn't mention, I just mentioned verbally just now in the presentation. We actually did the CTPA before even the CT abdomen, because hoping that we are catching a pulmonary AVM. But however, the CTPA was negative. Hence, with the portal anomalies, then only from the ultrasounds, then only we order for a CT abdomen, specifically looking at the portal venous phase. Then only we find out all these abnormalities. So I think there is no harm if you are very confident from your echo. Look, just like Olive shared in the previous case, being discussed with Dr. Martin, the PITS cardiologist here, they saw abnormal portal vein system. Hence, they straight away proceed with the CT abdomen to look at the portal venous system. Then they get the right diagnosis. But it was puzzle for us during the early phase of making the diagnosis, and we actually did quite a few imaging before we proceed to the specific one. Am I answering your question, Michelle?
Yes.
Yeah.
And then, sorry, can I clarify again? How many? What is considered delayed?
Theoretically, theoretically it's after 5 cycles. So usually the bubble
5 cycles.
test you will see after within third to fourth cardiac cycle. So anything more than that then is considered as a delay bubble test, delay positive bubble test.
So this child just now how many cycles? 3 cycles, 4 cycles? No, not really.
3 or 4 cycles.
3 or 4 cycles. So this child one is not delayed lah.
It's delayed.
It's
More than
delayed.
5 cycles.
More than 5 cycles.
Oh, more than 5 cycles. Okay. All right. Thank you.
So in a patient with liver failure, sometimes you do see hepatopulmonary syndrome, right?
Yes. Sure.
Yeah. Okay. So what is the thing? What's the good things that can the hepatopulmonary syndrome? The question is can the hepatopulmonary syndrome be reversed post liver transplant?
Liver transplant. I'm not sure. This is a hepato. Unless they find where's the shunt and restructure the vessel, I suppose.
No. The question is that we are not talking about this patient. So in a patient with liver failure ended up with hepatopulmonary syndrome. So will the hepatopulmonary syndrome resolve? Because that is a very important question, so that if you can understand it, then you can know what actually happened.
The hepatopulmonary syndrome resolved with liver transplant after liver transplant.
Yes. Will that happen?
It should, right? Because you already got a new liver, so you don't need shunt anymore. Then it should gradually resolve.
The shunt there is not okay. When the liver failure, so you got portal hypertension, then you do have other shunt to compensate, right? So you like the what do you call that, at the esophageal area and the splenic area, caput medusa over the anorectal area. So that shunt is because of portal hypertension. Yeah. Correct.
Liver transplant resolve the portal hypertension.
Yes, liver transplant resolve the portal. So this hepatopulmonary syndrome, although it's a shunt, it is not involved in this portal hypertension shunt. You get what I mean? Yeah. So there's no correlation at all for this portal the shunt, the portal systemic shunt, so-called portal hypertension leading to portal systemic shunt. So all these shunt, your hepatopulmonary syndrome shunt, it is not related to this shunt. So will liver transplant resolve the hepatopulmonary syndrome?
From my limited experience, it doesn't resolve because post liver transplant, we still need to support with like oxygen and nitric oxide for the hepatopulmonary syndrome. It will take some time before it resolves, but I don't know how long.
So the answer is that will resolve, right? It will take time to resolve. Yeah. Okay. So it is a potential reversible situation because you need to remember the pathophysiology. What's the pathophysiology here?
It's because of vasodilatation due to the nitric something, the angiogenesis something.
Yeah. So all the toxic substance, all the toxic substance by right to be cleared. By right to be cleared by the liver. So now you have a normal liver function already. So you can have the capability of you can clear out whatever the toxin already, and then all these can be reversible. Yeah. So there is a two different things. One is a toxin related, the other one is pressure related. So the portal hypertension leading to a portal systemic shunt, and then leading to the problem. Right? Okay.
Yes.
All right. Okay. All right.
And then can I
Yes.
So this patient that has this Abernathy malformation, is the global developmental delay. This child is not encephalopathic. I mean, there's hyperammonia, but at the same time, she has chronic hypoxia because of the shunt. So I suppose the hypoxia.
The child went home, right?
Went
So
home.
this child, despite the high ammonia, he is not encephalopathic, is it?
Not encephalopathic.
Okay, so there was no treatment given for the high ammonia per se, right? Okay, thank you.
Yeah. So what's the reason of high ammonia in this child who had relatively normal this thing?
There's all the toxin didn't go through the liver. Liver cannot.
Yeah. So despite a normal liver function, he had high ammonia because of that reason. So it's one of the very important diagnosis characteristic of Abernathy. So we have relatively normal liver function. As you say that the INR is normal, albumin is normal, but it's just the ammonia is high. Okay, so that lead to that. It's not looking about the urea cycle defect or the kind of thing, but then yeah, it's more towards like the bypass, the bypass of the. Good. Okay. So can I know who is presenting next week? Okay, bye. Can you look into the list? Yeah, who will be presenting next week for the sharing? Yeah. Right. Okay. So thanks a lot, Q, for the
Thank you,
wonderful
Dr. Chong.
presentation. Yeah. Okay. Then we will see you next week then.
See you next week. Bye
Okay.
bye.
Thanks. Bye.
Thank you.
Thank you. Bye bye.
Thank you. Bye bye.